Thank you very much for this kind invitation. I'm very honored. And you give a really good talk, which I probably would add some words concerning prostate cancer. Because prostate cancer is an immunological organ. And we know that in the early beginning, in every prostate, in every man, there is an increasing inflammatory infiltrate, which triggers the establishment of prostate cancer, the progression of prostate cancer. So in the future, we will have, I hope, we will have a lot of data on that issue. And I also want to add something to the discussion on antibiotics, because we know now that when prostate cancer patients are castrated, the microbiome in the gut changes. And there are some bacteria which learn to synthesize testosterone. So this may be one effect of how the cancer escape medical or surgical castration. But let's go to a kind of overview what we have in prostate cancer and what is new in prostate cancer this year. These are my disclosures, and I also have to add that I'm married with a urologist and oncologist, so if I have any questions at home, I can ask, and she translates it to me into the urologist's language, which is sometimes a little bit simpler. Systemic treatment in prostate cancer in 2021. What are the main learnings from the recent randomized controlled trials? Well, therapies move forward from the castration-resistant state to the hormone-sensitive prostate cancer state, and thus affecting the treatment sequence in metastatic castration-resistant prostate cancer. We have a novel, the first time a triple combination in metastatic hormone-sensitive prostate cancer, and finally, we have a new targeted drug, a PSMA-targeted drug in metastatic castration-resistant prostate cancer. This is an overview which I gave at a lecture at the European Urology Congress this year, and fortunately, I have to correct this slide for several times until now. If we go through this slide shortly, we have kind of three stages. We have the metastatic hormone-sensitive prostate cancer. Please do not say castration-sensitive prostate cancer anymore. We try to skip it. And here we have the backbone, which is androgen deprivation treatment. And then you can combine it with one of the new hormonal agents, abiraterone, enzalutamide, and apalutamide. You can combine it with prostate radiation therapy. Without any additional systemic therapy, you have a survival benefit. And you can combine it with docetaxel plus abiraterone, and that's new. Whereas ADT plus docetaxel alone, it will disappear because of the PEACE-1 trial. I come to that later. High-risk localized disease, not my issue today, but very, very new, and that will change everything. A new trial presented by Gero at the last ESMO showing that for the first time we have systemic treatment in localized high-risk prostate cancer which prolongs survival. That will change the sequence of treatment in the future. Then we have non-metastatic castration-resistant prostate cancer. Probably this will disappear with the new study which has been shown by Gero. And then we have metastatic castration-resistant prostate cancer. And here we have different agents which probably, since they went forward, will not be used in a castration-resistant setting anymore in the future. And we have probably a fourth kind of stage, the stage of badly vintage-treated metastatic hormone-sensitive prostate cancer patients. And if you look at these three lastly presented abstracts, more than 50% of all the patients with metastatic hormone-sensitive prostate cancer only gets androgen deprivation. So we are talking about a lot of combinations, we are talking about sequencing, but in fact more than half of the patients are not treated with all these drugs at all. And we know, and these are the data from the STAMPEDE study group, showing that ADT alone has a very, very, very bad outcome with 42 months median overall survival for those patients who are primarily metastatic. This also is valid for metastatic castration-resistant prostate cancer. Only 1/3 of these patients receives any therapy after a first-line androgen receptor-targeted therapy, that is a therapy with the new hormonal agents. So we are doing a very, very bad job. But before I start with treatment, some issues on the definition of metastatic hormone-sensitive prostate cancer. And everybody now who is dealing with prostate cancer will know what comes now. First, metastatic hormone-sensitive prostate cancer is based on a conventional CT of the thorax and abdomen and the bone scintigraphy. All randomized controlled trials have used for inclusion criteria and monitoring conventional CT and bone scan, except the VISION trial. I came to that later. But not a PSMA PET. PSMA PET is the best and the most sensitive examination we have, but PSMA PET is simply not involved in any of the clinical phase 3 studies. So if you do a PSMA PET, we have a lot of information, but then you have to tell the patients, well, we know there is a metastasis, but we don't know what to do because there are no studies. In the future, we will have trials on that issue, and that's probably one of the most exciting ones, the Primordium study, where we have for the first time an endpoint which is defined by a PSMA PET. So the new appearance of metastasis on the PSMA PET, done by a study with radiation, LHRH agonists, and apalutamide. Based on these two examinations, we have a risk classification. And this risk classification, it's simple, but it will play a very, very major role in the discussion which I will have with you now in the next minutes. We have high volume patient, that means 4 or more bone mets, at least 1 extraaxial or visceral mets. Everything else is low volume. And we have high risk, 2 of 3 factors, Gleason score 8 or greater, 3 bone mets, or measurable visceral metastasis. Everything else is low risk. And the most important thing on that definition is it tells us something about prognosis. If you have a de novo metastatic hormone-sensitive prostate cancer, you have a survival of 43 months if it's high volume. If you have a recurrent metastatic tumor, low volume, we have a survival benefit of nearly 100 months. Big difference. These are the recent trials in metastatic hormone-sensitive prostate cancer, and I will tell you something about the PEACE-1 trial, which is also a revolution in the treatment of metastatic prostate cancer. These are all the trials in the metastatic hormone-sensitive prostate cancer setting, and you see you have a hazard ratio which is comparable between 0.66 and 0.1, with an overall survival between 10 and 17 months. But what is the difference between the trials is the inclusion. Because, and I have shown you the slide before concerning prognosis, these trials include different patient populations. Latitude, with abiraterone, 100% de novo. But Enzamet, Enza plus ADT, versus ADT alone, also including some patients who got docetaxel, 61% only de novo. So you cannot compare these trials. Also for other reasons, different patient populations, different inclusion criteria, different endpoints, and so on and so on. We now have the first triple therapy in metastatic hormone-sensitive prostate cancer since PEACE 1. Therefore, I guide you a little bit through the study. PEACE 1, a trial presented by Karim Fisasi. It was a study to show that triplet with abiraterone and docetaxel and androgen deprivation treatment is better than ADT plus docetaxel alone in de novo metastatic hormone-sensitive prostate cancer. And this study was performed also plus-minus radiation, with a lot of stratification factors kept in mind in patients who have de novo metastatic castration-sensitive prostate cancer, who only need one lesion in bone scan or CT to be defined as metastatic. About 2/3 of the patients had high disease burden, so high volume. And these were the results. And the results were really intriguing. Abiraterone increases median radiographic progression-free survival in patients with metastatic hormone-sensitive prostate cancer by 2.5 years. So from 2 years in the control group to 4.5 years in the treatment group. Really, really good data. And there had a lot of been discussion before the overall survival were final that this is enough to give triple therapy, which is ADT plus abiraterone plus docetaxel versus ADT plus docetaxel alone. And then we had the survival data of the PEACE 1 trial. Adding abiraterone to standard treatment, so ADT plus docetaxel, significantly reduced the risk of death by 25%. And that's the overall population. Median overall survival in the control group, 4.4 years, not reached in the group with ABI. And then comes the discussion how to use it. And we only have major data on the high volume group, showing a survival benefit of 1.6 years. 1.6 years. So for the first time, we have a treatment which prolongs survival in the high volume metastatic hormone-sensitive prostate cancer groups over 5 years. For prostate cancer, that's completely new and intriguing. But it was only a subgroup analysis. So data for low volume patients are not major. It's only a subgroup analysis. And all the discussions on subgroups, and therefore I told you the definition issue on high volume and low volume and high risk and low risk, all the studies were not powered for that. Only for the whole group, and for the whole group, ADT plus docetaxel plus abiraterone is better than ADT and docetaxel alone. Side effects, only hypertension probably is an issue with this combination. Otherwise, really a well-tolerable treatment. And now comes a discussion, what should we do now? Should we give triple therapy to everybody? And then the interesting discussion starts. So there was a discussion if the double ADT plus the new hormones, enzalutamide, apalutamide, abiraterone, is really worse than the triple. And in fact, we don't know because it was only a comparison between ADT and docetaxel, and then you give abiraterone, and this is better than not to give abiraterone. But it was not a trial comparing double ADT plus hormones versus ADT plus docetaxel plus abiraterone. And some people were discussing, look at the data, look at the hazard ratios, which are pretty much the same between, for example, the Titan trial with ADT and apalutamide and the PEACE 1 trial. But of course, don't compare trials indirectly. So we have this data. These data are great. But interesting, because the data are very, very new, what did the experts say? And ask the experts, that's the Advanced Prostate Cancer Consensus Meeting 2021. So it was several days after Karim Fizazi have published the dates. And what did they say? And that was a little bit surprise, I think, to anybody. Interestingly, those who were voting then were commenting a lot differently from that. If you look at the question in which patients with synchronous metastatic hormone-sensitive prostate cancer that are chemo-fit, do you recommend the triplet therapy? ADT plus docetaxel plus abiraterone. And look at the data. 41% do not recommend this combi. 55% said only in high-volume patients. What's wrong on that? High-volume patient, only a subgroup analysis. And for 50% of those experts, and most of the experts there were the first authors of all the studies you have to think of. So there was a kind of not an agreement on whatever was asked in that meeting, and it also was on the triplet therapy. Next question, in the majority of patients with synchronous high volume, unconventional imaging, and now it comes or unequivocal on next generation sequencing. What is that? PSMA PET. So they included the PSMA PET, but there are no studies on PSMA PET included in the phase 3 trial. To which systemic treatment would be preferred? Again, no really good answer. The audience was divided. And next question. In the majority of patients without symptoms from the primary tumor with synchronous low volume metastatic hormone-sensitive prostate cancer, what is the preferred treatment additional to ADT? And that was the only consensus of all the questions which have been put. 77% said, okay, then we do a local radical treatment, radiation or radical prostatectomy, and we add systemic therapy, and we add metastatic directed therapy. Is this proven? Is metastatic directed radiotherapy proven? No. Do you need to add systemic treatment to radiation, local radiation, if you have systemic hormone-sensitive prostate cancer? No. That shows you how different these data, all the data we have now, are to implement in the daily clinical practice. Next question. A question we discuss everywhere in oncology and now also in prostate cancer. What if the patient with metastatic hormone-sensitive prostate cancer had a deeper response? Should we stop now the whole treatment, including castration? No answer. No definite answer. So 61% said, yes, we should discuss, but there are no data. There is no study showing interruption of treatment in prostate cancer until now. Next question, also very interesting question. What is your recommended treatment strategy in the majority of patients with hormone-sensitive prostate cancer that have low volume disease by conventional imaging, but high volume by next-generation imaging? So they do a PSMA PET, and PSMA PET show more metastasis, of course, because it's a more sensitive imaging. And again, 47%, nearly half of the audience said, then we treat this per high volume. But there are no data on that. I show you this slide just to make you sure that also the experts are discussing a lot, and they are not always doing what their own studies are saying. So what is our decision support on that issue? What should we do in clinical practice? That is a nice slide by Christopher Sweeney, who showed that if you have a patient who has a good prognosis, so this is the current metastatic prostate cancer patients, the metachronous patients, and who have low volume, give ADT plus ABI and SORAPA, and probably add radiation to the metastasis, where we have no data, by the way. If you have intermediate patients with intermediate prognosis, so about 4.5 years, metachronous or recurrent disease, and you have 4 or more bone mets, so high volume, give docetaxel or ABI answer, and APA, or give the triple. If you have a poor prognosis patient, 3 years, synchronous, 4 more bone mets, then give the triple therapy or put in trials. A slide for helping us. But of course, all the usual criteria play a role in personalized treatment selection. The preference lifespan, I've told you before, comorbidities, access, financial approval, safety, and so on. Metastatic castration-resistant prostate cancer. This is an overview of all the major trials. Not much in comparison to breast cancer, of course, but at least we have. And the 2 studies I want to mention, it's a CARD trial and it's a VISION trial. First of all these trials I've shown you before, which have only a limited survival benefit of 3 to 6 months, they were conducted in parallel. They have different comparators, different inclusion criteria, different endpoint definitions. You cannot compare them. And the optimal sequence is still undefined, therefore. Very, very, very important issue. What is about the re-challenge of new hormonal agents in metastatic castration-resistant prostate cancer, or in prostate cancer as a whole? And here we have a definite answer, besides other studies. We have the CARD trial. Randomized trial comparing cabazitaxel versus abiraterone and enzalutamide in castration-resistant prostate cancer. Only those patients were included who progressed on the prior androgen-targeted treatment within 12 months. And both radiographic progression-free survival and overall survival favors cabazitaxel versus alternative androgen receptor-targeted drugs. That means the patients got first Enza or Abi and then Abi or Enza. So this was achieved with, I would say, tolerable side effects. But interesting, look at cardiac disorders. Everybody tells us docetaxel, chemotherapy is cardiotoxic, so give new hormonal agents. No, it's not like that. If you look at cardiac disorders, 5% with Abi or Enza and only 1% with cabazitaxel. And that is in line with all the serious data which have published now. So it's very important to look at cardiotoxicity with the new hormonal agents. So no new hormones after new hormones, absolutely a no-go. And then we have a new vision, a new trial, a new substance, a targeted substance. We're always talking about personalized and targeted medicine. Now we have it at least concerning imaging. VISION trial. Phase 3 trial of a new substance, 177 lutetium PSMA 617. Patients who were eligible had at least 1 new hormonal agent and 1 or 2 taxane regimens. And they have to have 1 positive PSMA PET positive metastatic lesions and no PSMA negative lesions. They received lutetium every 6 weeks, 4 cycles to a maximum of 6 cycles, compared to a protocol-permitted standard of care. And what was interesting, and that was also discussed later on, 87% of the patients met the VISION imaging criteria for PSMA-positive metastatic castration-resistant prostate cancer. So the question came, do we need it? There are so many countries who had not access to PSMA PET or limited access. And nearly everybody fitting the criteria. And we don't know what is microscopic PSMA expression. Is it enough? We don't know. The primary endpoint was met, 15.3 versus 11.3 months survival benefit. Perfect. And also all the secondary endpoints. Look, partial response, 42% versus 3%. Great results. Also, PSA decrease. 1/3 of the patients had a PSA decrease of more than 80%, and most or a lot of these patients had androgen receptor-targeted drugs and 1 taxane and the other taxane. It was a far advanced patient population. And the side effects, I would say really minor. Not much nephrotoxicity, which we were before a little bit afraid of, and a little bit on bone marrow suppression. So again, the treatment landscape. Rapidly changing. A lot of discussions what we should do since triple therapy now has been included. And in the end, probably in the future, in the metastatic castration-resistant prostate cancer setting, we only have a Taxane, cabazitaxel, versus lutetium. And then there is also a study comparing these two, showing that there are a lot of advances with lutetium. So in the future, lutetium would be, I think, at least for some time, the first option in the metastatic castration-resistant prostate cancer setting. But we have the trials, as I told you before, also in the setting of metastatic hormone-sensitive prostate cancer, currently running. So also PSMA lutetium will go very, very early, I'm sure. PSA is not everything. We know that 1/4 of the patients had a PSA-negative radiologic progression, and these patients do worse. And we know that we have also patients with clinical progression without a radiological progression. It's very important to have this in mind, not to be too late with our treatments. So the take-home message for metastatic castration-resistant prostate cancer is we have novel targeted therapies. So do genetic testing and molecular imaging with respect to olaparib. No androgen receptor-targeted drugs after androgen receptor-targeted drugs because of cross-resistance. Monitor the side effects of the androgen receptor-targeted drugs also. Bone health protection, very important issue, but still urgent need for head-to-head studies. Thank you very much.
Thank you, Professor Kramer, for this great talk. I learned a lot. So are there any questions from the audience? I again have some technical issues here. I cannot see any online chat. Please.
In what time course do you integrate molecular tests like BRCA or microsatellite instability in prostate cancer?
Since I'm a mixed uro-oncologist, I do it very early because I see the patients very early. For me, it's important because if the patients are BRCA positive, it's a bad prognostic criterion. So I start early with the treatments, I monitor these patients more intensely, so I do it in all, and that's the NCCN criteria, I do it in all high-risk patients. And in the meanwhile, the patients knowing that, since we are trying to educate them as the breast cancer people have educated their patients, they're coming and asking for that.
Okay, thank you. I have a question. Perhaps a stupid question, but do you think is there a difference between this novel anti-androgen apalutamide or ANSA or ABI, or do you think the PEACE trial would have been more effective if you would have, of course this is pure speculation perhaps, but do you think there is any difference between those drugs, and are any of those more active compared to another one?
I think there is a consensus around all opinion leaders. There is only one androgen receptor target drug therapy, and I think they are equally effective. Of course, the differences in the androgen receptor targeted drugs are more on the side effect side. So darolutamide, which is a completely different drug, a different chemical drug, in my opinion, has less side effects than the others. But it's only approved for non-metastatic castration-resistant prostate cancer. The trial, the phase 3 trial in a hormone-sensitive setting is still going on. So all the drugs are equally effective. Probably there are some difference in the side effects, which make me use the one drug more than the other. Okay. But you can only attack the androgen receptor for one time.
Okay, and just another final question. Can you please also comment quickly on immunotherapy? Because you included pembrolizumab in your overview, And personally, I know it might be a bit
okay.
challenge, but what do you think?
Okay, you know that I'm coming from the field of immunology, and I told you the exciting data on bacteria producing testosterone
that's why I'm
in a
asking.
castration-resistant prostate cancer setting. I mean, that is really interesting, and we should revisit treatment with antibiotics, because you were talking about antibiotic could harm. Probably antibiotics are also useful. We don't know, but this should be the next direction of all the studies we have. We all know that prostate cancer is not that immunogenic, which we have hoped for, though we have positive trials with sipuleucel T. We are involved in a lot of trials with pembrolizumab. There's also one trial with pembrolizumab and lenvatinib. The results are promising. Concerning immunotherapy, I love the BiTE antibodies. Here the results are really great, the most promising data we had before. So I'm really, if I would have to set my money, I would set it on the BiTE antibodies.
Good to know.
Yeah, but yes, I think there is and that's what I'm saying for 30 years. There is a part for immunotherapy, a role for immunotherapy in prostate cancer, but in the neoadjuvant setting, very early. And I think all the treatments we have now in prostate cancer, they will get more earlier, but they will get in the neoadjuvant setting. And that is what we have to hope for, that here probably we could have the first cure in locally advanced prostate cancer with these drugs if you use it in the neoadjuvant setting. That's my belief, only my belief.